Starting.
Good evening. I'm glad you could join us tonight as we discuss outpatient total knee replacement. I'm Dr. Loel Payne. I'm an orthopedic surgeon with Tidewater Orthopaedics. We're going to talk tonight about what's involved with a knee replacement. We're going to cover what arthritis is so that hopefully we can get those questions answered for you that you may have. And then later on we're going to get into what's really new now in how we're doing knee replacements. We're going to get an opportunity to see the new Mako robot that we have here at the Careplex Orthopedic Ambulatory Surgery Center. You'll hear me refer to that as the COASC. It's a whole lot easier to say. And I'll hopefully be able to talk about what outpatient knee replacement is like, give you some examples of how we're doing that and what you can expect from the recovery. So thank you again for joining us tonight. At the end we're going to have questions, and I hope that everyone will be able to get all of their questions answered. So first of all, I want to talk a little bit about myself and the group. I'm with Tidewater Orthopaedics. We are a group of 10 orthopedic surgeons. What makes this unique is we specialize in only certain areas of orthopedics. So you're not going to find me doing a carpal tunnel surgery or a spine surgery or a hip surgery. All I do is shoulder and knee. We have hand specialists, we have spine specialists, we have joint replacement specialists, sports medicine specialists, and we all focus on that particular area. I think it helps us become more of an expert in that particular field. We also have 6 physician assistants who work with us. We've been in the Hampton area for over 45 years, approaching 45 years now, I believe. We're also in Williamsburg and have been in Williamsburg for about 15 years. And we're also really glad that we've been able to open an office in Suffolk within the past year or two. And that's continuing to grow for us as well. So we've been on the peninsula a long time. We're the largest orthopedic group on the peninsula, and we're really working hard to meet the demands of our patients. The COASC, the Careplex Orthopedic Ambulatory Surgery Center, is where I am right now. What makes this place unique is all we do here is orthopedics. It's one of the very few specialized surgery centers in the state of Virginia that's doing just orthopedics. That allows us to have, I think, some really outstanding results. We have less than a 0.1% infection rate. Most hospitals or surgery centers that you go to are usually pretty happy if they're getting a 1% infection rate. We're at least 10 times better than that. And I think that's part of the attraction of being in an outpatient surgery center setting. We do almost 4,000 surgeries here a year. We have, I believe, state-of-the-art technology and equipment. You're going to see that with the Mako robot I'm going to show you a little bit later. We believe this allows a faster recovery. You get to recover in your own home instead of being in a hospital bed. All of our staff are trained in just orthopedics. This is all they do. They do it all day long, and they're really good at it because of that. Same thing applies to our anesthesiologists. They do orthopedics. They are really good at nerve blocks. They know how to manage orthopedic patients, and I think that that allows us to really take very good care of our patients. Finally, also equally important, a lower cost being in a surgery center as compared to being in a hospital. So now let's talk about what arthritis is. First of all, a lot of people come to me and they say, I've got arthritis, what does that mean? Most people kind of think that it's an extra growth or something in the knee. It actually is not, it's the reverse. Something is wearing away in the knee, and that's the cartilage. We have cartilage shown here in this picture that covers the end of the bone, the light blue. I like to think of it as the Teflon coating. It's the smooth gliding surface. Every joint has cartilage covering the end of the bone so that when it moves back and forth, it's a nice smooth surface. When that cartilage wears away, that's arthritis. So the diagram here shows areas where you're missing the blue, the underlying bone gets exposed, And that's where the nerve fibers are located. So when the cartilage is gone, and the cartilage doesn't have any nerve fibers, it becomes painful because the underlying bone is now exposed, and that's going to be a significant source of pain. If that happens on both sides of the joint, that's when we start talking about bone-on-bone arthritis. That's the more severe form. So it isn't something that is extra growing there that we can just go in and take away. Unfortunately, the cartilage has worn away and we can't replace it. Cartilage doesn't grow back. As a result of the arthritis, you will start to get some bone spurs forming called osteophytes. Some of the cartilage will start to tear and be damaged, and all of that is the evolution of arthritis as it gets worse. So it starts off in just a small area. Over time, that area expands and gets greater to where eventually, as I said, it can reach the stage of being bone on bone. So, next slide. How do you know if you have arthritis? The best way to tell if you have arthritis is with an x-ray. We can see arthritis on an x-ray very clearly. And that's because cartilage doesn't show up on an x-ray. The bone does. So when we take an x-ray of a joint, we look for a gap between the bones because that's where the cartilage is located. So a normal knee joint in this example is going to have a nice space all the way across where the cartilage is located. When that cartilage wears away, that gap gets narrower and narrower until eventually the bones are touching. That's the bone-on-bone arthritis. So there's the complete loss of that joint space with now severe arthritis, no more cartilage, bone-on-bone. So that's how we diagnose our arthritis. It's best with x-rays. We can see it better than with an MRI. So that's an initial step that for somebody who's having knee pain, when they come into the office, we're going to get x-rays. With you standing up, that's going to show the compression of that joint surface better, and we can really get a good idea based on that how much arthritis you have, and that'll help us determine where do we go from there in terms of the treatment. Next slide. So here's an example again of a severe knee arthritis. This happens to be the same patient. So on one knee, they have severe bone-on-bone loss of the cartilage on the outside part of the knee, resulting in a big gap on the inside part. On their other knee, it's worn on the opposite side. They're bone-on-bone on the inside area of the knee, and more of a gap still on the outside. So these are an example of extreme arthritis. There's not any way we can make that cartilage grow back. The leg's going to get crooked as a result of the cartilage wearing away. And when the cartilage wears away, it frequently is just on one side of the knee. Why it wears on one side or another oftentimes depends on previous surgery or trauma to the knee, or maybe somebody was born a little bow-legged to start with, and that's going to make the inside part of the knee wear away a little faster. So these are pretty typical examples of knee arthritis where just one side of the knee starts to wear away, and as a result the leg is either going to get bowed if the inside of the knee wears out first, or become knock-kneed if the outside of the knee wears away. Next slide. So now let's get into what is a knee replacement. So we talked about the fact that we can't make cartilage come back when it's worn away. We can't go in and remove anything that's worn away. It's not going to really help. So when you reach the stage of getting close to bone-on-bone arthritis, we're really only left with the option being a knee replacement. So what we do with a knee replacement is the end of the bone is removed. It's capped with a piece of metal on each side, and then we put a plastic insert in between that will be the smooth gliding surface. And I'm going to show you an example of that. We have to get the knee straight. So a knee that has worn away on one side, and this example has become knock-kneed. You can see the the patient here lying in bed, how the knee goes out to the side because of being knock-kneed. We need to straighten that out again with the replacement. And we're going to get into a little bit as well in a second, how we have to make sure that the ligaments are appropriately balanced so that the knee moves well. So here's what the x-ray looks like with a knee replacement in there. We've made the knee straight again, and the joint has been replaced where it's no longer the bone on bone. There's a nice gap of where the plastic is. So a lot of people, when I describe a knee replacement to them, they think we're taking out a large segment of the knee, and that's not the case. A knee replacement is primarily just a resurfacing. So here's an example of a knee replacement. The end of the bone is removed where it has worn away. The upper thigh bone, the femur, will take off just enough bone to cap it with a piece of metal that is 1/4 of an inch thick. So that's all that's removed. We're not taking off large segments. We take off just enough that we can make a nice smooth metal surface covering the end of the bone. We don't want any bone exposed, so we want to make sure that the replacement covers the bone very well from side to side, as well as covering it very well from top to bottom. So that's how we do the top part of the leg, the femur, a nice metal surface all the way around. On the lower leg, the tibia, we make a nice smooth cut on the bone. And it's important that this cut is made at a 90-degree or perpendicular angle to the rest of the bone down the leg. That's what's going to help make the knee straight again. So we're going to make a nice cut at a right angle, perpendicular to the rest of the bone, removing just enough bone to resurface it again with a piece of metal. It has a little wedge on it that is made into the bone surface for fixation. And so that will be placed, again, making sure that we cover the bone very well without any overhang on the sides. So the metal part gets placed, and then a plastic liner, the white part, is inserted onto that metal, and that is replacing the cartilage. So now it will be the metal, smooth surface, moving back and forth on the plastic, allowing the knee to function without the bone-on-bone arthritis pain like you had before. This model doesn't show the kneecap, but the undersurface of the kneecap also gets replaced with a piece of plastic that will glide in a little groove in the metal as the knee bends back and forth. So this allows us to get rid of all the arthritis. There's no longer any exposed bone. It's all been covered by the metal. We've replaced the cartilage with the plastic. The tendons that move the knee, that control the kneecap, are left in place. So the leg is still going to function like it normally does, with the muscles contracting back and forth. And what's also important about a knee replacement is the ligaments, which connect bone to bone on both the inside of the knee and the outside of the knee, are left intact. And that gives the knee the side-to-side stability that it needs to keep it from being either too loose or too tight. So that's an example of what we do with a knee replacement. Next one. So as I said, with a knee replacement, it's important that we get the knee straight again. The way that we can tell if a knee is straight is not just by looking at it, although we sometimes will just eyeball it to make sure it looks fairly straight. But the guide that we use is that if we drew a line from the center of the hip to the center of the ankle, that blue dotted line should pass through the center of the knee. So that's a straight leg. Center of hip, center of knee, center of ankle. All of the weight is coming down in a straight line. It's not going to be thrown off to the side, which would make a knee wear out faster. So if we have a bow leg, the center of the hip and center of ankle blue line goes up, but the knee is going to be outside of it because the leg is bowed. Similarly, if you have a knock knee, it's the other direction. The center of the knee is now on the inside of that line from the center of the hip to the center of the ankle. And if we put a knee replacement in that position, it's not going to last as long because of the fact that the weight-bearing portion of the body isn't going through the knee joint, it's being thrown off to the side. And in fact, a number of studies have shown that we want to try to get that knee replacement within 3 degrees of being straight. So think for a second, if you have 2 rulers that you're lining up one on top of the other, and you want to make sure that they're lined up straight, perfectly up and down. It's pretty easy to do if you're able to just look at the rulers. But now, what would happen if you wrap one of those rulers in a pillow, which would be like the thigh, muscles of the thigh going all the way around it? Now you can't really see the ruler, and you're trying to line it up straight. And you need to be within 3 degrees. It can be a challenge. So the way that knee replacements are traditionally done, and this is the way that I learned how to do a knee replacement, I must admit, over 25 years ago, and it's still the way most knee replacements are done today, and I'll show you how that is. This is, I like to refer to it now as the old way of doing a knee replacement, although still the way most people do a knee replacement today. If we're going to try to line up that knee to make it straight, as I said, it's hard to do because of the muscles of the thigh. You can't really see where the leg is. So if we try to do that and you can't really see what you're looking at, you either have to make the incision a lot bigger, or you have to do some things to give you a better position. And the way that we do that traditionally is we put a metal rod in the center of the femur, in the center of the bone. So a hole is made at the end of the bone. This metal rod gets inserted all the way up the thigh. You can imagine that's going to hurt later. There are various little cutting guides or jigs that we put on the knee to then reference off of that center of the bone. So we put a guide, a little jig on the end of the bone. We put a couple of little pins in place like this to hold it in place. And then once we have it in that position, we can put our saw in through the little saw capture and make our cut. There are other cutting guides that can be used after we've done that to make the cuts for the top and bottom of the knee, as well as the various angles that we need for that femur to fit. So that would fit on now. We can make our cuts top, bottom, and get a fit for the replacement, as I showed you here with this model. We want to make cuts in the bone that look like that. So with these various cutting jigs, we can make those bone cuts so that the prosthesis will fit on there. So that's how the bone would be cut up above on the femur. For the lower leg, we don't have as much muscle covering it, so we usually don't have to put a metal rod into the lower leg bone, the tibia. We can kind of feel where it is, and we use a little guide here to help hold that in position. So this would fit around the ankle. We have a little cutting guide we can put on. We literally step back. Some people close one eye, make sure it lines up fairly well with the lower leg, put a pin to hold that in position, and it has a little saw capture. Again, we can cut the top bone to make it nice and smooth. So that's a traditional knee replacement. That's how, again, I was trained 25 years ago it's how most people are doing their knee replacement still today. In my opinion, it has a lot of guessing involved. We're trying to get it within 3 degrees, but we're eyeballing things to try to get it lined up to where it's supposed to fit. The cutting guides that we have, there's a little play in them as the saw goes past. So sometimes if it's a hard bone, the saw will skive off a little bit. It won't fit quite perfectly through the capture. And so therefore, since the cuts may not be perfect, a lot of people will use bone cement to help hold the replacement in place. It kind of fills in any gaps that maybe weren't perfectly cut with the saw. So most knee replacements still today are inserted using a bone cement to fix it onto the bone to help hold it in place. So that's the traditional way. That's not how we do it today. I wanted you to know kind of how most people are doing it and why the Mako has been such a revolutionary change for us in doing knee replacements. So let me get back and we'll finish up talking about the knee replacement. Go to the next slide. So one thing I mentioned before, not only is it important that we get the knee lined up straight and that we get the bone surfaces covered well with the replacement, but we also have to make sure that the knee is balanced, meaning that one side isn't tight and the other side loose. So if we start with a knee that is bow-legged, as in this example, over time the ligament on the inside of the knee is going to get tight and the ligament on the outside is going to stretch because the knee has been bowed for so many years. And if we put a knee replacement in there, we can't leave it that way because the knee won't be balanced. One side will still be loose and the other side tight. It won't move very well. Oftentimes will cause swelling and pain. So we have to try to balance the knee. So we've made our cuts, we've got our replacement in there. The ligament that is tight on the inside, called the medial collateral ligament, will oftentimes have to lengthen or release, make it a little bit longer to try to catch up to the ligament on the outside of the knee. So what I refer to as chasing your tail. You've made your bone cuts, and now you're trying to make everything else fit around it so that the knee replacement will work. So that's one area of trying to get a balanced knee. Next slide. The other thing that we have to do with a knee replacement that has to do with the ligaments is we have what's called flexion and extension gaps. And this is one of the biggest factors in why somebody either can't straighten their knee out all the way after a knee replacement or why it won't bend back very well after a knee replacement. So we've cut the bone now. I'll remove the parts. The gap between the bones is called the extension gap. So when the knee is straight, there's going to be a gap, and we want those gaps to be equal on both sides. And then when the knee is bent, there's going to be another gap now called the flexion gap, where my finger is located now. It's important that the gap with the knee bent is the same as the gap when the knee is straight, or else it's either going to be too tight when you try to straighten the knee, or it's going to be too tight when you try to bend the knee. And if one of those is tight, the knee isn't going to move as well. So in a traditional way of doing the knee replacement, we make all the bone cuts. We then try to get the ligaments side to side balanced. And then we again chase our tail trying to get the gaps between the knee being straight and the knee being bent to be equal. So there's a lot of variables into how we do a knee replacement to make sure it's going to work well. One thing that, again, we talked about how This is the traditional way of doing a knee replacement. And yes, it has been around a long time, 25 years or more. People have been doing knee replacements this way. But what we know is 1 out of 5 knee replacement patients aren't really happy with the result. And I think a lot of it has to do with these variables that we've talked about. Yes, we can make the bone cuts and get a knee replacement to fit on there, and it's not too hard to make sure that it's the right size. And while it's not real easy to make sure it's within 3 degrees, for somebody who does a lot of knee replacements, it's not much of a challenge for them to do that. But when it comes to getting the ligaments to balance well, to where it's not going to be too tight or too loose on one side, or to make sure that the knee's going to have full movement with the flexion and extension gaps being equal, that's much more of a challenge. And I think that that has a lot to do with why 1 out of 5 people with a knee replacement aren't real ecstatic about what they've gone through. Next slide. So I went through again the steps for a successful knee replacement. You remove the arthritic surface of the knee, you make it straight, you line up the knee joint within 3 degrees, you balance the side ligaments, medial and lateral they're called, you balance the flexion and extension gap so that you can get the movement, and then you insert the best size without it overhanging in either direction. So that's how we go about traditionally doing a knee replacement. Next. Now we get into the Mako. So what are we doing now that's so much different? In my opinion, this is a game changer for knee replacements. There are very few operations that I do now that I still do the same way I learned how to do them 25 years ago. Knee replacements similarly have evolved. Technology's gotten better. We can do so much more to take away these variables. My undergraduate training was at Duke, and I was an engineer. So I love data. I love seeing numbers. Give me as much information as you can to help me make a good decision. I don't like the uncertainty of, does it feel good? Does it not feel good? I want to know, is it right? And I think the Mako allows me to do that. So what is the Mako? It is a robot that we have that assists us in making the bone cuts much more accurate, very precise. People who are going to have a Mako knee replacement get a CT scan, a CAT scan, prior to the surgery. And this allows us to make an accurate model of what your knee looks like. Therefore, the incision doesn't have to be as large. I don't have to see quite as much because I've got the model already based on the CAT scan. This allows us then to plan the surgery based on that model before we've even gotten into the operating room. So again, less exposure during surgery. I think it's going to speed up your recovery. Also, it allows us to measure those gaps. So the gaps I was talking about, the space between the bones after we've made the cuts, I can measure those with the Mako before I've even made a bone cut. So there's no more guessing if something feels loose or tight. I know exactly how big that gap is. I can determine that before I've even done anything to cut the bones. I'm no longer chasing my tail. The bone cuts are then all made after the ligaments and gaps are balanced. As I said, you're able to do that all beforehand, and I think that allows us a much more accurate knee once we do that to put it in. Most people wonder with the Mako, is the robot doing the surgery? No, the robot's not doing the surgery. I'm still doing the plan. I'm still looking at it beforehand. We're picking sizes of the knee that we think are going to work best. I'm measuring the gaps to make sure I like how it feels and rotating or positioning the knee replacements to where we want it to go. And then when it's time for the saw cuts, I can bring in the robot and I'm holding it, and the robot gives me guidance to make sure that it's very accurate for where the saw goes. That allows us to no longer have to use cement unless the bone is really soft. to put in a knee replacement. So I can make sure that my bone cuts are so precise that I can put a knee replacement part on there that is a press fit. So it will securely go on without needing cement to fill in any gaps that may have occurred with the saw. The advantage of that is the bone grows into the press fit replacement instead of having the cement, which could be a potential source of loosening in the future. So I think that that's going to make the knee replacement last a lot longer by having the bone growing into it rather than using that cement. So here's an example of our plan on the Mako. So this is what it looks like as we're getting into the surgery. The green showing the femoral component, the bone of the covering the end of the thigh. The blue shows the tibial component. The Mako tells me the position of those implants. It tells me the alignment of the knee to make sure that I'm going to be within the 3 degrees. It tells me which size. I can determine, okay, I've looked at that, maybe I don't like that size, let's go down to a smaller size and see what happens. All of this is planned before I've done anything cutting the bone. Here are the gap measurements I was telling you about. It shows 18 and 18 on both sides in extension, and it shows 18 and 18 on both sides with the knee bent. So now I know my gaps on both sides of the knee, the medial and lateral sides are equal. My gaps with the knee straight and knee bent are also equal. My leg is lined up. I've made sure that the size I've selected for both the femur and the tibia are not going to overhang. And I haven't even done any bone cuts yet. This is all done ahead of time. So now, once I've done my plan, we can bring in the robot with the saw, make all the cuts very precisely, put the implants in, and it's going to move just like we planned. There's no longer trying to see if one thing is off, how do I correct that, then chasing it and trying to get something else to try to fit right, and maybe the size no longer fits. The accuracy here is remarkable. So I think this is going to really help us decrease that percentage of people who aren't happy with a knee replacement. I'm never going to tell somebody there's a 100% guarantee everybody's going to be happy. We don't have that capability, unfortunately, still in surgery. But I think it's going to significantly improve it to where there's going to be a lot more people happier with their knee replacement. It's going to move better, less pain, and I think it's going to make it last longer because it's going to be press fitted, it's going to be lined up well, and it's going to be balanced. And those are the things that we need to make sure a knee's going to last a long time. I generally tell people that knee replacements last maybe 20 to 25 years in general, but that's based on a lot of the older, conventional type of knee replacements we showed before. I'm hoping these will last longer. Well, time will tell, but certainly everything would indicate that that's going to be the case. Now, let's talk a little bit about outpatient knee replacement. So, traditionally, when we did knee replacements the old way with putting the big rod up the center of the bone, yeah, those were going to hurt. And oftentimes people would have to stay in the hospital 2 days, 3 days on heavy IV pain meds. Took a while to get up and be able to stand on the leg. But you can see now how if we don't have to put the rod up the bone anymore because we've got the robot and the computer doing the plan, and I don't have to make the incision as large because the robot and the model are helping me see what I need to do with the replacement, it's going to significantly help the pain afterwards. So we're now able to do these as an outpatient. And I have to give a lot of credit to our colleagues, the anesthesiologists as well. They, on their end, have really gotten to be experts at doing nerve blocks, meaning they give you a shot of Novocaine in the leg. It helps numb up part of the leg, but not all of it. And that really helps a lot with pain afterwards. And we inject Novocaine around the knee as well at the time of the surgery. So with an outpatient knee replacement, we have you upstanding and walking on that knee within an hour after we're done with surgery. Before you leave, we show you how to go up and down stairs. We make sure that you're walking safely. You're using a walker for balance, but you're up and walking and moving around so that within a few hours, you're ready to go home. So you're able to recover in your own home. That means a lower infection risk. You're not in the hospital. It's being done in a surgery center where we also have a lower infection rate. Potentially a lower cost, as I mentioned before, because of it being done in a surgery center and not in a hospital setting. And you're getting the state-of-the-art technology and pain management. How do you know if you're a candidate for an outpatient knee replacement? Well, it's important that you have a good support system at home. You're going to have somebody who's going to be there to help you get up and move. You'll be able to do it yourself, and as I said, we make sure that you're able to even go up and down stairs and walk with a walker before you leave. But it's nice to have somebody there who can help you when you need to go to the restroom or to get into bed. Usually after a couple of days, though, I find most people are getting to be fairly independent. You also have to be in generally good health. You can't have any significant heart trouble or lung trouble, COPD. We don't really like people who may have some difficulty breathing when they're asleep, sleep apnea. Usually that's associated with obesity, which could potentially be a problem. We want to make sure that you're going to be safe after the surgery. Dialysis patients are also, unfortunately, not a candidate for the outpatient replacements at this point. It's safer and better for them to stay overnight. But even in that case, most of them are going home the next day. And equally as important to how the knee replacement is put in is the desire to work hard for a good result. Knee replacements aren't easy. We're taking a large portion of the knee joint and redoing it with metal and plastic. There's going to be pain involved. The knee's going to swell. It's going to want to get stiff. I think with the Mako we're able to reduce a lot of those factors, but they're still going to occur. And we need an equal agreement here that I'll do my part on putting the knee in as best as I possibly can, and I need a patient to make sure you're going to do your part and you're going to work hard with physical therapy and you're going to work on bending and moving the knee and walking on it, and together we'll have a good result. Next. So here's an example of a picture of us doing a Mako. That's me and the taller one, of course, and my assistant Christian Johansson helping me. This is the Mako arm coming in. You can see I'm holding the saw, doing the cutting. It's not the robot doing everything itself, but it's guiding where the saw can go. I'm limited in where I can move the saw with the robot. It's making sure that I'm directly on plane, but I'm the one who's turning it on and off and controlling it. So let me show you the Mako real quick here, just so you can see what it's like. This is the computer screen I was telling you about that we used to plan the surgery beforehand. The femur is listed up above. This is the white is the bone of the CAT scan model that has been generated. The green is the different components, sizes that we've selected. In this case, we've selected a size 7 on the femur and a size 6 on the tibia. Can you show what would happen if we go to a different size femur?
I will downsize.
So we can, we'll say, well, maybe we didn't like that size 7. We wanted to go to something a little smaller, a 6. But now you can see when we've gone to the 6, there's a little bony overhang, the darker gray, which is starting to show up. So it's not going to cover the bone as well if I go to a 6. So I'm going to want to keep it at a 7. The same thing for the tibia. Go to a 7 there. So if we tried to go up on a size 7, maybe we could get that to fit. Questionably could overhang a little bit going into it, but it's pretty even on both sides. I might be able to make a 7 work. I would kind of see what it looked like when we got in there. But this will tell me how much bone I'm taking off, And then as the other screen I showed tells me what my gaps are going to be, and scroll through it just for a second. So here's again the model of the CAT scan with the component on there. I can scroll through to make sure that everywhere it's going to be a nice, smooth, even fit. There's not going to be any bone overhanging. This isn't something you can do with the traditional knee replacement. You have to try to eyeball it at the time of the surgery. I don't have to do that now. I can plan this out ahead of time, and I know which side is going to fit, which size is going to fit, where I want to put it to make it fit the best, and I think that's going to give us a much better result. So how does the robot know where your leg is? We have a ultra infrared camera that shines on the surgery field. We place, we call them arrays, these special guides that go on the bone. You can see it here in the picture of the knee replacement. These small little black circles there are the arrays that are attached to your leg at the time of the surgery, and that helps the robot know exactly where your leg is so that we can make sure everything is lined up well. So that is all done on the computer screen before I actually have done the surgery, and then when it comes time to do the robot part, this is the robotic arm that is brought into the surgery field. It would have a saw attached to the end here, which I hold the saw, and the robot is then going to help guide the saw exactly where the bone cuts need to occur. And so this is the robot, that's the Mako. Again, I'm still holding the saw and controlling it, but it's guiding exactly where it needs to go to make sure it's a very precise cut. And again, I think that's what's going to allow us better results long term, and it's also allowing us now to do this as an outpatient. So I'll be glad to take any questions at this point that people have, and hopefully I can get those answered for you and give you a little bit better understanding about, again, why I think this is game-changing technology for a knee replacement. This is allowing us now to kind of bring knee replacements into the 21st century.
All right. First question from Ms. Sharon would like to know if this procedure is only known to your practice.
No, excuse me. The Mako initially started 12, 15 years ago with just partial knee replacements. It has now evolved to where we're doing knee replacements and hip replacements with the Mako. Soon, hopefully, we'll have shoulder replacements with the Mako robot. So the Mako has been out now for a while. It is in several different hospitals around the area. We're, I believe, one of the few doing it in a surgery center, which kind of makes it fairly unique. But no, there are some other places where you can find Makos.
All right. Wayne would like to know what happens when you've had a reconstructed knee due to shredded ligaments.
So with shredded ligaments, we're usually going to be talking about the ligaments in the center of the knee, the cruciate ligaments, the ACL. That's the most common ligament that will tear, and it will, as a result, make the knee loose and unstable. When the knee is loose, it's going to wear out faster. Just like I was explaining to you, a knee replacement will wear out faster if the ligaments aren't working well. The same thing, if you tear ligaments in the knee and it's looser, it's going to make it become arthritic a little bit faster just because of it being looser.
All right, Wayne would like to know, is the implant a custom-made joint?
No, this is not a custom-made implant, primarily because we're able to plan everything with the Mako beforehand, what size is going to fit the best. So I can much more accurately determine the size that's going to fit your knee. And the problem, I've done custom implants as well in the past. The problem with a custom implant is you're limited to putting it where the custom tells you it needs to go. With the Mako, as you saw, I'm able to adjust it. If one size doesn't fit well, or it's not giving me the balance that I want, I can change that implant to make sure it's going to be accurate. With a custom implant, you go into surgery, you got one option. There's no plan B. All you got's plan A, and you better make it work. That's why I like the advantage of this is I can adapt on the fly if I need to, based on my plan with the Mako.
All right, Liz would like to know, does the Mako make recovery any easier?
I believe that it does, because it is reducing the size of the incision. It is placing rods up the center of the bone, which would be painful. And it is allowing us, I think, to get a better fit for the knee, and that's going to help with the overall recovery so that it moves better.
All right. Do you do partials, and if so, is the Mako a part of this procedure?
Yes, I do partials, and the Mako will soon be a part of the procedure here. They do have the option for doing a partial with the Mako. We hope to have that portion of the technology here very soon.
All right. What is the lifespan of a typical knee replacement?
So, as I said earlier, knee replacements typically last about 20 to 25 years. The average number that the literature would say is that 1 out of 100 knee replacements will fail every year. That's the statistics. So at 10 years, 10 out of 100 have failed. At 20 years, 20 out of 100 have failed and would have to be redone. So we typically will use the number 20 to 25 year life expectancy for a knee replacement, but that still means 80% are still going strong, even at 20 years. And that's with the older designs and the older technology. So I'm hopeful that with the newer designs, maybe we're going to get even a little bit better than that.
All right. Does insurance cover Mako?
Yes. Unfortunately for the patient, this is no additional cost to the patient. It doesn't get billed to the insurance. The Mako cost is borne solely by the hospital, and in this case the surgery center that purchased it. We did that because we think it's going to give us better results, and therefore that's what we're after. We're going to benefit in the long run if our patients are happier. So for us, the surgery center or the hospital that has the Mako bears the additional cost. There's no additional cost for the patient except for the CAT scan ahead of time. That's the only additional potential cost. You do have to have a CAT scan prior to the surgery, and you may have a certain copay or something that goes along with that.
All right. Does the Mako cut down surgery time?
The total surgery time, I think, will be improved as we go along. There's still a certain amount of time that's going to be required one way or another. I think that it probably will trim it off a little bit of time. Overall, I wouldn't expect a great major reduction, however.
All right. If you have to be hospitalized, could you still use the Mako?
So for patients who do require the overnight stay, Centera is going to soon, I believe, allow us to do the Mako there. As of currently today, December 2nd, 2020, we're not allowed to. I think that's going to happen in the next couple of weeks is my hope.
Okay. Does this surgery fix a torn PCL?
The PCL is one of the main ligaments in the middle of the knee that keeps the lower leg from shifting backwards on the upper leg. Many knee replacements will keep the PCL intact. If you don't have a PCL or the PCL is not functioning well, there's a different design of a knee replacement that we can use that takes that into account. So you don't have to have a PCL to have a knee replacement. We can do a knee replacement in somebody who doesn't have one. It just requires a slightly different design, which can still be done with the Mako.
All right. This person had surgery in January for a torn meniscus and arthritis, but their knee is still painful and swollen. would this be a good choice for them?
It would depend on how much arthritis we see on the x-rays. And that's the big determining variable. If you had an arthroscopic surgery for a torn meniscus and the knee's still swollen, the great majority of the time it's because you have pretty significant arthritis in your knee. So we would get x-rays. If the x-rays show that you're getting pretty close to bone on bone, and you're not responding to things like cortisone shots and anti-inflammatories and other attempts at treating you without surgery, then yes, a knee replacement may be a very good option for you.
All right. Are there fewer revisions with this procedure?
At this point, we don't have the data to say that for sure. I personally believe that it will be the case because we're putting it in lined up better and better balanced with the ligaments. Time will tell if it's going to result in lower revisions. So I think it will. We just don't have the numbers yet to prove it.
How long is the recovery and what limitations do you have on activities?
Knee replacement recovery, no matter what, takes a while. This is one of the slower, harder recoveries. It's harder than a hip replacement. It's harder than a shoulder replacement. And that's because no matter how easily and smaller incisions we can do with knee replacements, they tend to swell and get stiff anyway. So most people are in physical therapy for 2 to 3 months, working on getting the knee bending and helping them with the walking. So the recovery depends on what we're talking about to be fully recovered. In general, most people are walking with a walker at first, and I tell people expect to use a walker for a week or two. Some are often less than a week. Some may take 4 weeks. But in general, a week or two with a walker. Maybe another week or two with a cane after that. Again, some are often much faster than that. Some take a little bit longer. By 2 months, you're usually walking pretty well with typically much less pain than what you had prior to the surgery. Your knee's still a little swollen, it's still stiff, we're still working with physical therapy to get the full flexibility back. But things are progressing. Usually by 3 months, you're left to just do the exercises on your own. But it can take 6 months to a year before it's really starting to feel more like a normal knee.
So, and once you've gone through all your PT, would you be able to resume your normal activities?
Yes, I tend to let people do most everything except we don't like a lot of pounding on the knee such as running or jumping. It's a mechanical part. The more pounding you put on it, the quicker it may wear out. So getting back to golf, getting back to tennis, walking, great, do it, it's wonderful. Biking, certainly fine. I wouldn't try to pick up running or something where there's a lot of jumping and impact type sports to it, but you can get back to most other activities. If you have to kneel, we usually recommend a pad that you kneel on, a cushion, because we do replace the backside of the kneecap, and so kneeling on a hard surface may be a little bit uncomfortable, but otherwise you're doing most everything else.
All right. How long has the Mako been in use, and how long have you been doing the procedure with the Mako?
So the Mako has been in use, as I said, altogether, starting with the partial replacement for 10, 12 years. 2006. The knee replacement application for the Mako has been much more recent, just within the past few years that we've been doing a knee replacement with the Mako. We just got the Mako here at the COASC 2 to 3 months ago. And so we've been doing it here. I actually trained on the partial replacement back probably 2010. I pushed hard for the hospital to get it back then, and I never could convince them. So I've been doing Mako, if you really want to count it, goes back 10 years. But that was just with the partial. Now it's just been more with the full replacement.
All right. Do younger patients usually go home the same day?
Yes. Younger patients are typically going to go home the same day. They're healthier in most cases and are able to get up and get walking fairly quickly with this.
All right. Do people see you after surgery for follow-up or your PA?
So in my practice, I like to be very much involved. So The only time you'll see my physician assistant, unless there's an emergency, is you'll see him prior to surgery just to make sure that any potential medical issues and the blood work and all of that's appropriately taken care of. They give you your medications that you'll need to have them filled prior to the surgery, so you'll have them at home. They make sure that everything's tuned up and ready to go. And then you'll see my physician assistant at about a week and a half after the surgery, just for the initial wound check. From then on out, you're seeing me. I see you back at 4 weeks, I see you at 8 weeks, I see you at 12 weeks. So the rest of the follow-up is with me. There's just those 2 times. With the wound check, I use super glue on my incisions for a total knee replacement. A lot of people use staples. I like the super glue on the incision because there's a waterproof bandage that covers it. So I let you shower the next day. That's a nice thing about being able to do this as well. Going home, there's a waterproof bandage. You're able to shower with the knee replacement. It makes life a whole lot easier instead of having to try to keep it dry.
Are you the only doctor in the practice using this technology?
No, Dr. Higgins and Dr. Kingston are both doing this technology for knee replacements. They both do hip replacements as well, and I think are also going to be using the technology for the hips. As I said at the beginning, I don't do hip replacements, but I'm hoping that when the shoulder application comes out, we'll be using it on the shoulder as well.
All right, this is a tough one. What is the cost, and is there any negotiating with uninsured patients?
The cost is going to depend on the insurance, and it's just the cost of a knee replacement. Again, there's no additional cost for the Mako part. So each insurance is going to have a different cost depending on your copay, things along those lines. And yes, for uninsured patients, there are reduced rates that we do to try to make it something that's an option for you there as well.
How soon can surgery be scheduled?
Surgeries for knee replacements, we get a CAT scan ahead of time. That's something we can usually do pretty quickly. If there's no significant medical problems, then I usually don't send you to have called a medical clearance with your primary care doc. We will go ahead and can typically get things scheduled within a month usually. Depends on what time of year it is. This is a busy time of year, but it kind of depends on what we're faced with, but it usually doesn't take a very long time to get things scheduled.
All right, and is there more pain or less pain when using the Mako versus the old procedure?
I think there's certainly less pain with this procedure than with the old way. Again, not having to put the metal rod up the center of the bone, smaller incision for what we're having to do to be able to see things in the knee is going to make it less painful.
All right, does this significantly reduce recovery time?
In the long run, I think it will, because I think we're going to have you up and moving quicker. I'm hoping there's going to be less pain. There should be, and all of that's going to speed up the recovery.
All right, so there is no more questions. Been going about an hour. I think we can sign off.
Very good. So if you're interested, you can make an appointment online at tidewaterortho.com. You can also call our office, 757-827-2480. Be glad to see you. I'll show you the x-rays. We can talk about how much arthritis you have and what options are available to you. Thank you. Thanks for joining us tonight.